Hello, this is the first video on female reproductive anatomy and physiology. This will be one of three parts. In the first part, I'm going to look at the organs of the female reproductive system, starting with the vulva all the way up to the ovaries, and also talk a bit about the mammary glands. In the subsequent videos, I'm going to look at oogenesis and folliculogenesis and do an overview of kind of the development of the different follicles and their different stages. And then I'll tie that in with the HPG axis and the regulation via hormones. And then in the final video, we'll look at the female sex hormones, specifically the different types of estrogens, the estrogen receptors, talk a bit about progesterone, and a little bit about androgens as well. So for this first video, the anatomy review might be familiar to some of you, so you don't have to necessarily go through it in a lot of detail, but just be sure to understand all the major structures that we're going to be talking about later. I'm also going to emphasize the role of the endocrine system and how it maintains the structure and function of these different organs. Okay, so for the important organs that we need to be familiar with here, we'll start with the ovaries. This is homologous, of course, to the testes in males. This is the site of oogenesis and the production of the oocytes, the actual eggs that will, when fertilized with sperm, become the zygote. The ovaries are also the site of stroidal genesis, so production of estrogens and progesterone in particular. We'll look at the uterine tubes, the oviducts, also known as oviducts or fallopian tubes, and then the uterus, the uterine structure. This, of course, is the site of conception and pregnancy. And then we need to know something about the external organs, the vagina, the vulva, the perineum, and the mammary glands. So we'll start first with the external genitalia. And this would be the vulva, also known as the pudendum. The vulva is found within the perineum, which is the area of tissue at the base of the abdomen, which contains the external genitalia and the anus as well. The vulva contains several structures. The mons pubis, this is the region that is anterior to the vaginal and urethral openings. It covers the pubic symphysis bone, and it's an elevation really of adipose tissue, and it's covered in pubic hair. The labia majora, this is the region on the edges of the vulva. This is homologous to the scrotum in males. These are two longitudinal folds of skin. They extend inferiorly and posteriorly from the mons pubis. They're composed of adipose tissue, they're sebaceous and sweat glands, and pubic hair. And then there's the labia minora inside of that. And these are smaller folds. They're medial to the labia majora. There's no pubic hair, adipose, and only a few sweat glands, but there are a lot of sebaceous glands, which gives it a lot of inner moisture. And this is homologous to the spongy or penile urethra. And then the clitoris, which is at the anterior end of the labia minora. This is a small cylindrical mass, and it's at the junction of the two labia minora on the anterior end again. It's composed of erectile bodies made up of corpora cavernosa. Remember, in the penis, that's the same spongy vascular tissue which is responsible for penile erection, so the clitoris also is able to become erect during sexual arousal. And this also contains nerves and blood vessels. The surface of the clitoris is known as the glans clitoris, and this is homologous to the glans penis in males. So during sexual excitement, the clitoris enlarges, becomes very sensitive to touch, and so forth. And then there's the vestibule, and that's the region between the labia minora. So that's all the region that's sort of depicted in this diagram down here. And this is homologous to the membranous urethra in males. And it contains, if it's still intact, the hymen, which covers the vaginal orifice itself, and then the external urethral orifice, so the urethra here on the anterior side. Let me do this in blue. And there's also openings to a couple of glands. So there are paraurethral or Skene's glands on either sides of the urethra, and these are homologous to the prostate in males, and they secrete mucus and prostate-like secretions. And then there are greater vestibular or Bartholin's glands down here by the vaginal opening, and they secrete mucus, and they're homologous to the bulbal urethral glands in males. And then there's openings to several other lesser vestibular glands as well that help secrete moisture and different fluids onto the vestibule. The bulb of the vestibule is two elongated masses of erectile tissue just deep to the labia. It's on either side of the vaginal orifice, and this becomes engorged with blood during sexual arousal. And that helps to narrow the orifice, and that puts pressure on the penis during intercourse. And this structure is actually homologous to the corpora spongiosum in the bulb of the penis in males. So it's sometimes helpful to look at those homologous structures to kind of link one reproductive system with another. So it's interesting how the different structures like the prostate have similar roles and functions in terms of their secretions in male and female physiology, but they have quite different anatomical expressions. So moving from the vulva inward, we next come to the vagina, and this is a tubular, just under 4 inches or so, elastic fibromuscular canal. It connects the introitus to the lower end of the uterus at the cervix, and the anterior end is actually closed normally before any sort of penetrative sexual intercourse by the hymen. And this is a thin, vascularized mucous membrane. And then the fornix is the recess surrounding the vaginal attachment to the cervix. And there's 3 layers to the vaginal wall: the mucosa, the muscularis, and the adventitia. So in some ways similar to the wall of the bowel or the ureters or something like that. So the body follows the same sort of threefold plan when it comes to the structure of these different mucosal tissues. So the vaginal mucosa, the innermost layer, is composed of non-keratinized stratified squamous epithelium with an underlying lamina propria. And that lamina propria is rich in blood vessels and different lymphatic channels. There's 3 layers of cells. There's a basal stem cell layer up next to the lamina propria. They're intermediate cells. And then there's superficial cells, which are constantly shedding, and then the basal cells are replacing them. So just like very similar to skin. There are folds called rugae. These are a series of transverse folds, and that increases the surface area when the vagina is stretched. Now, keratinization can occur if the mucosa is exposed to air, and that might happen in a vaginal prolapse when the vagina is expelled through or hangs through the vaginal introitus. Different secretions occur here. So there are secretions from the uterus, from the cervix, but then the vaginal epithelium itself has a transudate fluid. And then there are, of course, the Bartholin's glands that we talked about before. Estradiol is very important for vaginal wall homeostasis. So the estradiol effects are to cause the intermediate and the superficial cells to store glycogen. This also is going to happen in the endometrial cells in the uterus. But in this case, glycogen, again, this is a storage form for glucose. The estradiol causes a thickening of the vaginal epithelium because of that. The epithelium thickens at puberty, and then it starts to thin with the drop of estradiol at menopause. So low estradiol states, we see a dry, thin epithelium. There's little glycogen, and that's very susceptible to infection. The other thing is that there's a microbiome that's part of the vaginal mucosa, and I'll talk about the vaginal flora here in just a moment. But one of the roles of the lactobacilli in the microbiome is to metabolize the glycogen down into glucose and lactic acid. And this is going to help maintain the normal vaginal pH of around 7.8 to 4.5. And that's going to help prevent colonization with different bacteria and so forth. The acidic vaginal environment is also hostile to sperm, so the alkaline nature of the semen actually helps to neutralize that for the passage of sperm. And the thickness is going to, obviously, with the change in estradiol through the menstrual cycle, the vaginal epithelium will change in thickness as well. The vaginal flora is a very complex ecosystem. It actually forms a biofilm, and that changes throughout life, again, depending largely on the estradiol concentrations, but to secondary effects, progesterone and FSH as well. This vaginal flora really resides on the outermost layer of the vaginal epithelium. There's sort of a mucosal layer, and then it sits on top of that. And this is dominated by lactobacillus, again, which helps to maintain the acidity of the vaginal terrain. And the lactobacillus also secretes bactericidins, hydrogen peroxide, which are all antimicrobial. So this helps to prevent colonization with other bacteria. And then the vaginal immunity is actually maintained by the mucus layer, by the microbiome, and there are many aspects to the innate immune system. One is the secretion of defensins. This is the same with the gut. Defensins help prevent colonization of different bacteria. There are, of course, dendritic cells and antigen-presenting cells, which are constantly doing immune surveillance. The actual acidity here in the vaginal terrain, and then secretory IgA also. So all of these have to be in place to maintain proper immunity. And if that breaks down, there's more susceptibility to vulvovaginitis, which essentially is inflammation, but that's typically caused by bacteria. I'll go through that here in just a minute. Going deeper, we have the muscularis, and there's an outer circular layer and an inner longitudinal layer of smooth muscle. And this can stretch considerably. And then there's an adventitia consisting of areolar connective tissue, and that's going to anchor the vagina to the adjacent structures in the pelvic floor. The anterior end is anchored to the urethra and the urinary bladder, and the posterior end to the rectum and the anal canal. And unfortunately, a weakening of that adventitia can result in a cystocele, which is where the bladder protrudes into the vagina, or a rectocele, where the rectum actually protrudes into the vaginal cavity. There are different supporting structures to the vagina. So there are the vaginal artery is a branch of the internal iliac artery, and there's a uterine artery. There are lymphatic vessels, and then the right and left vaginal vein drain into a deep vaginal venous plexus, which then drains into the internal iliac vein. And there are both autonomic, sympathetic, and parasympathetic nerves. The parasympathetics come from the pelvic plexus. The sympathetics largely from the lower thoracic segments, like T12 to like about L1, L2. And then the pudendal nerve, which is part of your voluntary motor system. And the examination of the vagina, of course, involves the pelvic exam, which we do with the speculum. So we're not going to cover it here. This is covered more in gynecologic discussions. But some of the terms we need to be sure we know, of course, is dyspareunia. This is painful sexual intercourse, and that often can result from vaginal atrophy, from a thinning, for example, after menopause, or inflammation of the vagina from the causes I'll talk about here next. And that is vulvovaginitis. And that can be caused by yeast, candida, bacteria. That would be bacterial vaginosis, and Gardnerella is the most significant bacteria there. Different parasites, trichomonas would be the characteristic one there. Other STIs like chlamydia, very important cause of pelvic inflammatory disease, which is infection and subsequent inflammation of the lower the lower pelvic organs. And then different viruses, HIV, human papillomavirus, very important here for cervical cancers, and then genital herpes as well. Allergies, atrophic vaginitis, which is the low estrogen state, and then aerobic vaginitis. So all of these are different examples of vulvovaginitis. The vagina is susceptible to different cancers. Actual squamous cell vaginal or vulvar cancer is fairly rare, but more common would be cervical cancer. And then the different vaginal abnormalities like imperforate hymen, transverse vaginal septum, vaginal agenesis in fetal development, vaginal fistulas, vaginal cysts, and then I talked about the pelvic organ prolapses, rectocele and cystocele. So these would all be different disorders of the vagina to be familiar with. Next, we come to the uterus, or the womb. This is the site of implantation of the fertilized ovum and where the fetus develops. It's also the source of menstrual blood flow if the implantation doesn't occur. It's located between the urinary bladder and the rectum. It's about the size and shape of an inverted pear, and it's larger in females who have been pregnant and smaller with lower estradiol levels, like after menopause. The different anatomical divisions are the upper part of the uterus, which is called the fundus. And this is sort of a dome shaped. I think it's best seen in this picture here. This is the fundus here. So there's the fundus, and that's actually superior to where the uterine or fallopian tubes enter here. And then there's the body, which contains the bulk of the uterus, the body of the uterus. And then the cervix, which is this end down here, where it goes into the vagina. So the cervix itself contains smooth muscle, there's a cervical canal, and there's a little opening into the uterus, that's called the internal os, and then there's an opening into the vagina, that's the external os. And this is a very important region because this is where The cells which line the body of the uterus are primarily glandular columnar epithelium, and those are the same kind of cells in the fallopian tubes as well. So that's the glandular columnar epithelium. And then we, of course, in the vagina, remember, have squamous cell epithelium. And so there's a region in the cervix where these two types of cells meet, and that's called the squamo-columnar junction. And that's actually visible typically when we do a gynecologic exam, the speculum exam. You can actually visualize that change in tissue there. And this is an important area because this is an area where cervical cancers often develop. And we see the movement of the with different hormone stimulation, whether it's in early puberty or later in life towards menopause or after menopause. The junction either moves outward more into the vaginal canal, or it retreats back up into the uterus. So it's going to change with a woman's age and hormone secretions. There are various ligaments which attach the uterus to the pelvis. So the broad ligaments, they fold over the peritoneum and attach to the pelvic cavity. I'll show you a picture of that as we go here. And then we have the uterine sacral ligaments. They connect the uterus to the sacrum, the cardinal or lateral ligaments, and then round ligaments which attach the uterus to the anterior abdominal wall. And the body usually is projecting. If you kind of look at how the uterus is situated, it's usually projecting over the bladder. So this is the anteflexion, the sort of classic form of how the uterus sort of aligns itself. But it can also be retroflex. It can point more posteriorly, and that's usually not an issue. It can, in some cases, impede with menstrual flow. It can also impede with fertility, but that's the posterior positioning of the uterus. The uterus can prolapse, and this can be due to weakening of these ligaments and the various pelvic muscles. That can be due to age or disease, different traumatic vaginal delivery, pelvic tumors, and there's various degrees of prolapse, 1, 2, 3, 3 being the worst. And there's different exercises that are given, from more supportive for the early stages of prolapse, like pelvic exercises. Pessary devices are inserted into the vagina to help maintain support for the uterus, or surgery. The cervix secretes mucus, and these are produced by secretory cells in the cervical mucosa, and it's a mixture really of water and glycoproteins, lipids, enzymes, salts. During reproductive years, there can be as much as 20 up to 60 milliliters a day secreted of cervical mucus. It's less viscous, more alkaline around the time of ovulation, and that's going to help assist sperm and their ascent up the vaginal canal through the cervical os into the uterus. At other times it becomes more viscous and actually forms a plug in the cervix to prevent the passage of sperm or other bacteria, etc., up into the uterus. The mucus actually has the glycoproteins and whatnot, actually helps the energy needs of sperm. So again, that's going to assist sperm. And it also helps with sperm capacitation. Remember, that's the activation of sperm. And that's through things like heparin and so forth that activate that. All right, so that's a little bit about the important structures there. But again, estrogen, in this case, does have an important role on not just maintaining, in the case of the uterine epithelium, but also on maintaining a healthy sort of squamo-cervical junction, squamo-columnar junction, and so forth. So we'll talk a little bit more about that as we go. Now, important for understanding the menstrual cycle is the fact that the uterus actually has 3 different layers. There's the perimetrium, which is the outermost layer, and that's actually part of the visceral peritoneum. And it's composed of simple squamous epithelium. The lateral part actually becomes the broad ligament, which is going to help also anchor the ovaries. On the anterior side, it covers the bladder, forming the vesicouterine pouch. And then on the posterior side, it covers the rectum, forming the rectouterine pouch. The sort of muscle layer of the uterus is the myometrium, and there's actually 3 layers of smooth muscle there. The muscle's thickest in the fundus, and it's thinnest towards the cervix, or at the cervix. There's an inner and outer layer, and these are composed of longitudinal and or oblique muscle, and then the middle layer is circular. So this is going to assist in uterine contraction, for example, during the menstrual cycle, during the period, to kind of expel the endometrial lining, which we'll look at here shortly, or during pregnancy, of course, and delivery, to expel the fetus. So that's the middle circular layer, and one of the main factors which regulates muscle contraction is oxytocin. So oxytocin from the posterior pituitary is going to stimulate uterine smooth muscle contraction, and that's going to be important in labor. The endometrium is the innermost layer of the uterine wall, and that consists of columnar epithelium. And there's two different types. Some are secretory and other epithelial cells are ciliated. And they're actually going to assist when the, for example, the fertilized zygote becomes the blastocyst. I'll review that here in just a second. When that's going to be ready for implantation, the cilia are going to help with that process. So that's the epithelium. There's a stromal layer underneath that, which is made up of thick lamina propria or connective tissue. And then there are endometrial glands, which are invaginations of the epithelium into the myometrium. So it's not a clear division between the endometrium and myometrium. The endometrial tissue dips down, it points into the myometrium. The endometrium is divided really into two layers, and this is important for the menstrual cycle. So there's a basal layer, which is a permanent layer, and that's going to give rise to new cells. But the functional layer, which is on top of that, is what's sloughed off during menstruation. So that's the basal layer allows for a continual regeneration of the functional endometrium after menses. At peak development, right before menstruation, the endometrium is about 4 to 5 millimeters thick, typically. And it's going to thicken during especially the luteal phase of the menstrual cycle. So if you look at this picture over here, this shows the endometrium at the different stages during the menstrual cycle. So here's cycle day 1, so that's right at menses. And then here is around ovulation, on day 13 through day 14. Again, we'll go through this in more detail coming up here. And then here's the luteal phase, or the second half, and notice the actual thickening. And if you look inside the endometrium, again, there are these deep invaginations. These are part of the glands, endometrial glands. And then there are these arteries which become very spiral and tortuous-like, and they're going to feed the endometrium. And then underneath that, we have this more constant basal layer. So basically at menses, all of this outer layer is going to be sloughed off. And you can see that here already with menses is starting to thin here. And then we're left primarily with the basal layers, and that's going to help regenerate then for the next menstrual cycle, the endometrial lining. So that is the 3 layers of the uterine wall. The blood supply to the uterus comes from the internal iliac artery, which branches into the uterine arteries, and then the arcuate arteries. And the arcuate arteries are the ones that are going to give rise to these little spiral arteries. There are little radial arteries. It's not shown, actually it's shown in this picture up here. So here's the uterine artery branching into the arcuate artery. And then we have these little projections coming off the arcuate artery in the myometrium. And then we have the spiral arteries, and then little side branches here. These are the basal arteries, and this will supply the blood to the basal layer of the endometrium. The veins, the drainage is through uterine veins into the internal iliac veins. Now, different uterine disorders, again, this is more covered in gynecology, which we won't be covering in endocrinology. If you're in an acupuncture section watching this, this will be covered in a separate video. But uterine disorders like uterine prolapse, there's carcinoma of both the cervix and the uterus, leiomyomas, also known as uterine fibroids. These are benign tumors of the myometrium, the smooth muscle. Adenomyosis are growth of endometrial tissue into in the myometrium. And then endometritis, myometritis, this is inflammation or infection of the endometrium and myometrium. There are uterine malformations, and an important one for endocrinology is Asherman syndrome, and this is intrauterine adhesions or scarring, usually due to DNC procedures, dilation and curettage, like after, for abortion. So that can unfortunately cause scarring in the uterine wall, and this could be an important cause of secondary amenorrhea, which we'll talk about in the pathology section. Hysterectomy is surgical removal of the uterus. uterus, and this can be partial or subtotal, and that's removal of the body but not the cervix. It can be complete, which is removal of both the body and the cervix, or radical, which is removal of the body, cervix, and uterine tubes, usually with the ovaries as well. And as a result, the hormone production is going to obviously be absent, and that might require hormone replacement therapy. All right, so those are just some important uterine disorders. Again, this is more covered in gynecology. Next, we have the uterine or fallopian tubes, also known as the oviducts, and they lead from each corner of the uterus toward the ovaries. Each is about 10 to 15 centimeters long. There's three different regions. The infundibulum is a trumpet-shaped area with little fingers called fimbria, which folds over each ovary. And then the ampulla is the main part of the fallopian tube, and that's going to be the most common site of fertilization, and I'll show you what happens there in just a moment. And then the isthmus is what connects the uterine tube to the uterus itself. Again, there are three layers here as well. There's the mucosal layer, which is made up of epithelium and lamina propria. And there's two types of epithelium. There's ciliated columnar epithelium, and this forms what's called the ciliary conveyor belt, and that moves the ovum down from the infundibulum down into the isthmus and into the uterus. Certain things can actually damage that cilia importantly, so we know smoking for one. Chronic cigarette smoking can damage that, and that can actually lead to infertility. There's something called Cartagenar Syndrome, which is a genetic condition, and that's where we don't make adequate cilia, and one place that shows up is here. That's also going to affect the lungs as well, because we have lots of cilia in the respiratory epithelium. But here, the lack of the cilia primarily will lead to infertility, because there's little likelihood that the fertilized ovum is going to move its way down the fallopian tube. There's also non-ciliated columnar epithelium. These are called PEG cells, and they have microvilli, and it secretes fluid to kind of help moisten and lubricate the uterine tube canal. And then there's a muscularis layer. There's an inner circular smooth muscle layer and outer longitudinal smooth muscle layer, and there are different peristaltic contractions which move the ovum down, as well as that's also assisted by the cilia. So both the muscular contraction and the cilia help to propel the egg down the fallopian tube. And then there's a serosal layer on the outside. The function is, typically this is the site of fertilization. That can happen up to 24 hours after ovulation. The egg can live that long. If we look at where fertilization usually happens, it's primarily in the ampulla. So that's this region in here. And when a sperm and an ovum actually combine, they become a zygote. So if you look at the typical process, we have ovulation from the ovary here. It enters the infundibulum, and then it travels down the ampulla of the fallopian tube, and usually somewhere in here the fertilization occurs. So in this particular diagram they've depicted it here, and when egg and sperm combine, they form the zygote. And then the zygote is going to undergo a series of cell divisions, becoming the morula and going through different phases here, and then eventually it's going to form a little hollowed out structure with a little fluid cavity, and that's called the blastocyst. And that happens towards the end of the first week after fertilization. And then roughly about a week, 6 to 8 days on average, the blastocyst will actually begin to implant in the uterine wall, and then it's going to migrate into the uterine wall. And then the outer layers of the blastocyst will actually help form the placenta together with the myometrium. And then it's the inner layers of the blastocyst, this little cell mass right here, which will divide further to become the future embryo. And that will, interestingly, also the different developmental stages happen in 1 week intervals. So in week 1, we form what's called the embryonic disc. In week 3, we form a trifold germ layer. In week 4, that's where you see some of the primordial organ structures really developing, and so forth. So each week shows a different developmental milestone. Okay, so that's one of the roles there, obviously, is to help with fertilization. Now, unfortunately, the embryo could be fertilized and could actually, several things can happen. One is it can attach outside the uterus somewhere, and this is what forms an ectopic pregnancy. The fetus usually does not survive, except in very rare occasions, depending on if it's maybe on one area of the uterus and it's able to actually form a proper placenta there and so forth. But typically ectopic pregnancies are most concerning because they result in, or can result in, severe bleeding, and that can even lead to hypovolemic shock and death. In fact, ectopic pregnancies are the most common cause of death in women in the first trimester. About 90% occur in the uterine tubes. This is called a tubal pregnancy, so it's going to implant in the tube and not down in the uterus. Can also occur in the cervix and the ovaries and the abdomen. The zygote can actually, unfortunately, move out of the infundibulum and into the abdominal cavity, and they can attach anywhere along those sites. The diagnosis typically is, a woman might do a pregnancy test, find that she's pregnant, but then she starts developing severe lower abdominal pain and so forth. We're going to confirm that with an elevated HCG. HCG, I'll talk about that coming up, but that is a hormone secreted by the placenta, and that's actually going to help maintain the corpus luteum, which we'll go into. But HCG is also the marker we use for pregnancy. So there'll be an elevated HCG, and then an intravaginal ultrasound, which is better than a transabdominal ultrasound, will be able to usually detect the mass of growing tissue. And the treatment, there are some medications that can be used, methotrexate, etc., but the primary treatment is surgery for the more concerning ectopic pregnancies, and that's usually done laparoscopically. So that's ectopic pregnancy, and that's a little bit there on the uterine tubes. And then we have the ovaries. These are almond-shaped reproductive glands. They're located close to the lateral wall of the pelvis bilaterally. Again, they're homologous to the testes in males, and each weighs, in an adult, about 8 to 12 grams, so not very large. And they descend into the pelvic cavity during the 3rd month of development. The functions are really gametogenesis and folliculogenesis to produce the oocytes. These are the egg cells, and then steroidal genesis for sex hormone production. So estrogen, progesterone, also other hormones like inhibin and relaxin, which we'll discuss here shortly. There are different ligaments anchoring the ovaries. So the broad ligament is a folding. Here you see very clearly the broad ligament. It's a fold of the peritoneum, the parietal peritoneum, which attaches the ovaries to this double layered fold of peritoneum. There's the ovarian ligament, and that anchors the ovaries to the uterus. And then we already talked about the round or suspensory ligament, which helps attach the ovaries and the uterus to the pelvic wall. The histology of the uterus, of the ovaries, is if you look at the outer surface, there is a layer of epithelium known as germinal epithelium. These are altered peritoneal epithelial cells. And this is actually the source of most ovarian tumors, is this outer germinal layer. There's underneath that the tunica albuginea. We saw that in the male reproductive physiology. This is a whitish capsule of dense irregular connective tissue. It's located immediately below and deep to that germinal epithelium. And then there's the cortex, which is the outermost sort of region of the ovary itself. So that's all this out here. That's the cortex. And this is where the ovarian follicles reside. And the follicles are all at different stages of the development. So this picture here, although you see this kind of picture in all the textbooks where you start with the primordial follicles, and then you go to more complex graphene follicles up to the corpus luteum. This is not correct. We have in the cortex follicles at all different stages of development at any given time. And there's also dense irregular connective tissue between the follicles, and that contains stromal cells. And then deep inside, we have the medulla of the ovary, which is more loosely arranged connective tissue, and it contains blood vessels, lymph vessels, and nerves as well. The follicles are found in the cortex, and they consist of a oocyte, the egg, and surrounding cells, and these cells are going to help the egg cell mature. The oocytes are in different stages of development, so they are actually in different phases of arrested meiosis. We'll go through that. The follicles also are in different stages of development. So The single layer of surrounding cells around the oocyte is follicular cells, and then outside of that are granulosa cells. So they form several layers. And these secretions from the cells actually help to nourish the developing egg cell, as well as these are the sources of estrogen and progesterone as well. And then once the follicles get to a certain stage of development, we call them mature or graphene follicles. And these are follicles that are large, fluid-filled, ready to rupture. And they expel what's called a secondary oocyte, which is going to ovulate. And that's going to enter the uterine tube. And then when it's actually going to undergo a further stage of development right before the sperm combines to form a complete egg cell. The remainder of the follicle that's left behind after the egg is expelled after ovulation is called the corpus luteum, or yellow body. And this contains, again, the remnants of the follicular cells. And this is what produces primarily progesterone in the second half of the luteal menstrual cycle, known as the luteal phase. It also secretes some estrogens, relaxin, inhibin as well. If no fertilization occurs, this is going to degenerate into a little area of whitish connective tissue called the corpus albicans. So that is the major structures we see there in the cortex, and I'm going to go through all these in a bit more detail here coming up. Important ovarian disorders, again, this is more part of gynecology, would be ovaritis, endometriosis, where we have endometrial tissue which grows actually on the outside of the ovary, and it responds to the hormone stimulation during the course of a menstrual cycle. Ovarian torsion, very similar to testicular torsion in males. Ovarian cysts, ovarian rupture from the cyst rupturing. Polycystic ovarian syndrome, PCOS, where we have multiple follicles in different stages of arrested development. Anovulation, where we don't ovulate. Hypogonadism, not secreting enough of the steroids, especially estrogen and progesterone. Premature ovarian failure, again, that's a type of hypogonadism. And then ovarian tumors and cancer, there's various types. So those would be the important ovarian disorders to be familiar with. Again, we're going to go through some of these as we go through, especially the reproductive endocrinology. Finally, the last important organ we need to understand here before we begin looking at hormones and whatnot are the mammary glands, the breasts. These are exocrine glands found within each breast, and they produce milk. The breasts themselves are attached actually to the muscles, so we have the anterior thoracic wall muscles, the pectoralis major, and the serratus anterior muscles. And there's a layer of dense irregular fascia which is going to separate the breast from the muscle. Then there are suspensory ligaments of the breast, or Cooper's ligaments, which extend between the skin and the fascia, and that helps to maintain support for the breast, and those ligaments become looser with age. There's one nipple found in each breast typically, and that contains closely spaced openings of ducts. These are the lactiferous ducts, and the milk emerges from the ducts. The areola is the pigmented area around the nipple, and the areola itself has modified sebaceous glands, so it gives it a rough appearance. The mammary gland itself, they're found within each breast. They're modified sweat glands, or sudoriferous glands, and they secrete milk. Each gland has 15 to 20 lobes, and they're separated by adipose tissue. So if you look at the diagram here, here's a lobe. And then inside each lobe, there are several lobules that contain glands called alveoli. Don't mistake that with pulmonary alveoli in the lungs. There are myoepithelial cells. Myoepithelium is a special type of epithelium with actin myosin. So when those muscle proteins contract, they act like little muscles. And that is going to expel the milk from the mammary glands. The milk's going to flow from the alveoli to secondary tubules to mammary ducts, and then to what are called lactiferous sinuses, which are just under the nipple. These are controversial. Prior to around 2005, a lot of textbooks talked about these, and I think newer research is not finding that we actually have these. But either way, the mammary ducts will eject milk through the nipple then. important things to know about the physiology of lactation. So with lactation, that involves synthesis, secretion, ejection of milk post-gestation. With early breast development requires really two primary hormones, estradiol and growth hormone. And again, growth hormone is activated. It binds to receptors in the liver cells, hepatocytes, which then secrete insulin growth factor. So it's really IGF-1, which is the primary active form of growth hormone. And then estradiol itself is going to promote differentiation of the milk ducts. Growth hormone just promotes growth of all the different structures. And then testosterone, unfortunately, will inhibit milk duct formation. And then there's other hormones that assist this as well. But primarily think of estrogen, growth hormone in early life is leading to breast development. With pregnancy, there are different hormones, and specifically prolactin is going to actually stimulate milk secretion. And then estradiol and progesterone are going to be needed for duct development. And progesterone levels go very high. And the rising progesterone is actually going to inhibit any sort of milk being expelled, but it's going to help proliferate the ducts. After delivery, the progesterone is going to drop, and the first milk, known as colostrum, is released. And this is very rich in proteins, especially immunoglobulins and fatty acids. And then it's oxytocin, which is going to stimulate the myoepithelial cells to contract, causing milk ejection. So again, remember, prolactin is going to help with milk synthesis and production. Estrogen, progesterone help with the duct formation, and it's oxytocin, which is going to allow for the milk letdown reflex. And that's going to be released in response to nipple stimulation or suckling. Weaning involves, the loss of suckling is going to cause prolactin to drop, which will cause decreased milk production, and that's going to allow for partial involution of the alveolar structures. And then postmenopausally, a decrease in estrogen and also growth hormone is going to cause atrophy of the mammary gland tissue, and the glands become smaller. So that's some of the roles of hormones in maintaining breast health and development. Different breast disorders, fibrocystic changes, fibroadenoma, again, this is more covered in gynecology, mastitis, Paget's disease of breast, a type of breast cancer, mastalgia, nipple discharge, galactorrhea, and then thrombophlebitis, forming of blood clots, and then breast cancer. So we're not going to go through all those here. These will be discussed more in gynecology, or again, if you are in Chinese medicine watching this video, we'll talk about these in a separate video. Okay, so that covers it for the basic organs, structures, and whatnot that we need to know as we now launch into some of the reproductive physiology in the next videos.